is Dustin Nelson, and today we're going to be doing 3 images for a Zygomatic Arch series. We have 10 by 12 because our hospital does not carry 8 by 10s. We have a 40-inch SID. Our first image we're going to do is the AP axial town method, and it's going to get both the Zygomatic arches. We have a 30-degree caudal angle all set up. That's the first one we're going to do. The next view will be the tangential, so it'll be a double 15-degree angle tilted the head towards the affected side, so this will only get the one zygomatic arch. Then we will do the SMD, the submental vertical, and that'll give both zygomatic arches again. We have shielding for our patient. We have a chair for them to sit down in. Like I mentioned, the AP axial town is going to be a caudal angle of 30 degrees. The tangential and the SMD will be a horizontal beam. So we'll put this in now. And we'll go get our patient. Marissa?
Yes.
How's it going? My name is Dustin with Radiology. We're just going to be taking 3 images of your zygomatic arches, it sounds like, of your face. First off, could you verify your first and last name and date of birth?
Marissa Oliver, 7184.
Perfect. And any chance you're pregnant?
No.
All right. Have you, so what happened? What have you given these?
I got hit by a softball on my left cheekbone area.
Okay. Have you had any x-rays before on this area of the face?
No.
Any surgeries or anything? Any personal history of cancer? Okay. So we're just going to do 3 images. So if you want to go ahead and grab a seat, I got some shielding for you. Help protect you from excess radiation. Okay. All right, so the first image we're going to do is an AP axial town method. So we're going to get the OML perpendicular to the IR by tilting the head up, tilting the head down. We have a 30-degree cauded angle on the tube. If we couldn't get the OML perpendicular, then we would do the IOML and tilt the tube at 37 degrees cauded. But we're going to be able to do the 30-degree cauded because we're going to get the OML perpendicular. We want the mid-sagittal plane perpendicular to the IR as well, and we want the central ray to enter 1 inch above the nasion, so around the glabella. So the first thing we're going to do is get our CR center. There, just want to close your eyes really quick. Again, we want the OML perpendicular with the IR. There, so that's perpendicular. Our central ray is entering 1 inch above the nasion. We have our mid-sagittal plane perpendicular with the center of the IR. And we have your patient shielded. We're going to put on our right marker. Side, come down a little bit. There, careful not to clip off what we're trying to see, which is the zygomatic arches not overlapped by the mandible. So just hold that steady. All right, Marissa, so just stop breathing. Beat. Alright, Marissa, so got that one. We're going to do our next view. Switch out our IR. We're still using a 10 by 12 because our hospital does not have 8 by 10s. Otherwise, we would use an 8 by 10. So the next view is going to be our SMD. So we're going to get the OML parallel with the IR this time, but we are going to have a horizontal beam. So we're going to lower this down. It's lined up. Close your eyes. We want our central ray 2 inch or 1 inch posterior to the outer canthus, and we're going to, just like the previous view, it's a bilateral view of the zygomatic arches. So we're going to go ahead and scoot you forward just a little bit, and if you can tilt your head back, perfect. There you go. We're going to get the mid-sagittal plane perpendicular to the IR and also centered to the IR. And then we want the we want the OML parallel with the IR, so they're on the same plane, which is what we have achieved. We want the central ray just 1 inch posterior to the outer canthus. Centering more. That. Get our right marker on there still. We're going to come down. Raise the IR just a little bit. So it's lined up. Right. View. It's not a fun view for the patient to hold, so we're going to go ahead and hurry up. But again, we have the OML parallel with the IR, mid-sagittal plane perpendicular, centered perpendicular. We have our marker on, patient's shielded, and we're getting the zygomatic arches free of superimposition. So I'm going to set this hold still. Beep. All right, so our final image we're going to do, we're going to switch out our IRs one last time. We're going to do the tangential zygomatic arches, double 15-degree angle. We already have her in the SMD, which we want the OML parallel with the IR. So we're just going to scoot her over just a little bit, just because we want to just get the unilateral arch on this one. So and that's pretty centered. So take off our right marker. So as a unilateral projection, we still want the OML parallel with the IR. We are going to rotate the patient's head 15 degrees towards the side of interest, which she said it was her left side that hurt. So we'll rotate her 15, and then we're going to move the top of the head 15 away in order to isolate the zygomatic arch and get it free of imposition. We want to do still 1 inch posterior to the outer canthus. Just skimming the cheekbone. Put a left marker on there. Right there. All right. Hold still. Beep. Alright, Marissa, so that should be it. Relax. Let me just go run these, make sure you got everything the radiologist wants to see. Looks good, so if you want to just go ahead and hop up, we will get the lead back from you. It's not a souvenir. And if you want to step right this way. Alright, so these are our images for the zygomatic arches that we did. Our first one is our SMV, our submental vertical. And with this one, we got both zygomatic arches in there. We have good collimation. We have our marker. We used a cone, and we could tell that there's no rotation. They are symmetric without foreshortening, and the zygomatic arches are free of superimposition of the rest of the skull. And as you can tell on the left zygomatic arch, they have a fracture, so we did good in getting that information for the radiologist. Our next image is our modified apiaxial town. We have the zygomatic arches, and they're not overlapped by the mandible on either side. There's no rotation of the arches, and both the arches are lateral to the mandibular rami. So we did good on this one. We left out our marker, but we'll just have to remember that for next time. But we did get everything the radiologist needs to see. And then we have our tangential, the double 15. The zygomatic arch is free of superimposition of anything. We have good collimation because we include the entire arch. And and then we didn't overexpose and burn it out. We can see, we actually see some of the cheek, so we did pretty good on our technique. We have our marker, good collimation. So those are our images for the zygomatic arches.